This is the Emergency Medical Minute, sponsored by CarePoint and HCA Health One.
My medical minute today is going to be on something we see pretty commonly in the ER, urinary tract infections. So it's really going to be about the diagnosis of UTIs. I think it's just really important because there's actually a lot of harms that come when this is done incorrectly. So just when thinking of patients that actually have a UTI, there's a couple of criteria that are there. How many of you have ever had a patient dropped off by EMS and what they say is, smells like a UTI? Have you ever heard that?
Yes.
Right, it's like, so foul smelling urine is not a symptom and is not part of any criteria for a UTI. Neither is cloudy urine. There are other causes of that are not infections. And so I think it's just important to kind of go through that. It's very basic, but sometimes just the basics are, really where we get the most bang for our buck. So first off, you have to have symptoms. I know that sounds basic, but I heard it put this way: you can't have disease without dis-ease. You need to have symptoms, right? So you have to have, and ideally localizing symptoms. So that's suprapubic pain, dysuria, frequency, hesitancy, urgency, something like that. You have to have that. Then on the urinalysis, what is the thing that we actually care about? There's all these data points on it. What is the thing that matters? So we've heard two different things already. I'm hearing someone say nitrites. I'm hearing someone say leukocyte esterase. The answer is white blood cells. So the white blood cells are what matters. So it's pyuria. You need to have a white blood cell count greater than 10 to actually be a sign of an active infection. And then lastly, to confirm the diagnosis is something that we're not going to have the luxury of having, but that's culture positive urine with over 100,000 colony-forming units. And this is because there's a distinction between colonization and infection, right? It's like we are covered in bacteria. There's bacteria all over us. There's probably more bacterial cells than human cells, which is kind of crazy. But if you swab one of our mouths right now, you're going to grow bacteria on it. That doesn't mean that you have an infection right now. So there's a significant portion of patients that have asymptomatic bacteria. And there was a review done in 2017 which showed that 45% of patients, that's almost half, who were treated with antibiotics for a presumed UTI actually had asymptomatic bacteria, and they didn't require it at all. And so that's really important because it's incredibly harmful if you're doing that. So we're treating patients with antibiotics who don't need it, so we're messing up their gut microbiome. We're causing adverse reactions to antibiotics, so abdominal pain, diarrhea, vomiting, putting them at increased risk for multidrug-resistant infections. And then really the biggest one that I worry about is, are we missing some other diagnosis, right? They're coming in for some complaint and they're coming in with maybe a stroke, and we get a urine and we see something on them, we're like, oh, they have a UTI. So we just explain it away as a UTI, and that's how you miss stuff. That's how you miss ascending cholangitis, and that's how you miss a stroke, and that's how you miss heart attack or whatever. It's really important to hone in on, do they have localizing symptoms? Do they have positive white blood cells? And ideally culture positive urine. So that's just the features that are really required to actually have a UTI. And it's important to remember that so we're not just labeling patients as that every time. Anyway, yeah.
So why do we get so many urines then on people if they don't have any symptoms?
Yeah, totally. It's a great question. And it's because there's this tension between efficiency in the department, because we know that the rate limiting step for a patient is often getting a urine sample. And so there's a balance between, you don't want someone to be waiting in the emergency room for hours and hours. There's also unnecessary risk you're exposing them to the longer they're here. You're jamming up the department by preventing other patients who are not being seen in a timely manner in triage, who have other important diagnoses that need to be evaluated. So it is important to get these quickly. And there's tension between the risk of overtesting and the risk of not processing all the patients in a timely manner. And that's a really difficult kind of philosophical balance. And it might be the case that, we should just obtain urines on patients really quickly. Now, whether or not we as providers need to order it is a separate question that I'm that this is probably more focused on, like the appropriate ordering of a urine, but obtaining it for testing is definitely more efficient if you can just get it quickly. So that's probably my best answer to that, but it's a really good point. You don't want to overtest. Are there any other questions on this? All right, well, that's the Medical Minute. Let's have a good day today.
This has been the Emergency Medical Minute. Thank you to our sponsors CarePoint and HCA Health One. Support from them and listeners like you helps us to continue providing free medical education to the masses. If you found this episode valuable, consider supporting our work and check out the link in our show notes.